Okay, Diabetic Retinopathy by Mathew Yonan. So, breaking down diabetic retinopathy with medical terminology. Let's see what this really is. First, the diabetic part there. So, diabetic retinopathy is primarily caused by diabetes mellitus, both type 1 and type 2. And I say primarily because it also could happen in pregnancy because of elevated blood glucose levels, but it's primarily caused by diabetes mellitus. So diabetes mellitus type 1 is an inability for pancreatic beta cells to produce insulin, and diabetes type 2 is reduced insulin sensitivity. So the retinal part is having to do with the retina. So the retina is a sensory tissue that lines the back of the eye, helping convert light stimuli into electrical signals, which is also called, that process is also called the phototransduction cascade. Okay, and so the pathy part is the medical term for disease. So the punchline here, essentially putting these three together. So diabetic retinopathy is a disease of the retina caused by diabetes mellitus. Okay, so let's start with the anatomy of the eye, the basic anatomy. So we have the cornea, which is the outer layer, the layer which light first passes through. Then we have the retina, which is what we'll be focusing on today. It's basically the first layer of the back of the eye. That's essentially sensory receptor tissue containing photoreceptors like rods and cones. Okay, then we have the optic nerve, which is sort of an extension of the retina that leads all the way to the back to the occipital lobe of the brain to help process that visual information. Okay, then we have the retinal artery and vein, the fovea, and the fovea is basically a place on the retina with concentrated area of cones, and it's basically the center of a place called the macula. So the fovea is actually really small part there, essentially. Okay, then we have the vitreous humor, which is a clear gel that makes up the inside of the eye, around 80% of the eye. Then we have the pupil, and the pupil essentially it decides how much light is let in, and like it can be constricted or dilated depending on whether you're in a dark room or a light room. And then you have the lens, and the lens essentially focuses the light on the retina. So that's very important. So after that, this is the back of my own right eye. That's right. I had an eye exam around a week ago, and I asked them if I could have an email of my own fundus photography, also known as a fundoscopy. And so here, what are we looking at here, right? So over here, that little white opening is the optic nerve opening or the optic disc. So that'd be like right here, okay? And then over here is the macula, which includes the fovea, like right in the center. Oops, which is like right there. Okay, so one sec. Okay, so we have the three stages of diabetic retinopathy. We have diabetes without retinopathy, non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy. Okay, so diabetes without retinopathy. So let's look at the pathophysiology. So wait, diabetes without retinopathy, that doesn't make much sense, right? Because we're talking about diabetic retinopathy. Well, it actually does, and it's considered a stage of diabetic retinopathy because of the underlying high blood glucose or hyperglycemia, which causes damage to retinal parasites. Now, you may be asking, what are retinal parasites? So retinal parasites are actual smooth muscle cells that are found on the walls of blood vessels, which help regulate flow throughout the retina, sorry. So they're actual cells that are in the retina that are on top of capillaries in the retina, essentially. Just like this picture down here. This is not necessarily relating to the eye, but you can just see how the parasites look on capillaries there. So weakened parasites means that the capillary walls in the retina are weaker. Okay, and although this doesn't cause any vision symptoms or visible changes in fundoscopies, it can lead to the next stages of diabetic retinopathy in the future. Okay, so here we have, this is taking a look deeper to seeing how parasite damage actually happens because of hyperglycemia. Because I feel like saying high blood sugar leading to parasite damage is kind of a jump. So we start with glucose, and this high amount of glucose enters the endothelial cell of the capillary, which leads to something called an advanced glycated end product precursor. Okay, and then this is then turned into advanced glycated end product plasma proteins, which then activate RAGE receptors, RAGE receptors on a macrophage, which then after a couple processes in that macrophage lead to adhesion molecules, chemokines, and cytokines, which are produced, which actually activate inflammation, which then leads to the parasite loss and a couple other things that are actually important, like vascular permeability, edema, and capillary dropout. So that's where the parasite loss comes from, essentially. So what are the health implications of this first stage? So in this stage of diabetic retinopathy, the patient has no visual problems or symptoms. This stage is almost always present in most people who have had diabetes mellitus type 1 and 2 for a few years because of long-term hyperglycemia. As it builds up, you get more parasite damage. And so this parasite damage is not detectable through fundus photography. You can imagine it's really small. I mean, it's in the retina, right? However, it is detectable through non-clinical means such as a microscope. So the punchline here is that damage to the retinal capillary wall is still occurring at this stage, but it's not clinically detectable. All right. So obviously we can't actually treat it because we don't know what's happening, right? So let's go right to prevention. So since this stage is not clinically detectable, there's no treatment. Prevention of diabetes without retinopathy stage is synonymous with standard treatment of diabetes mellitus. And I mean, this makes sense because we're not going to be able to control the actual damage of the parasites, preventing it from growing, but we can actually prevent it from starting in the first place by keeping our blood sugar low, right? So frequent blood glucose monitoring and control, annual eye exams, patient compliance with the diabetic diet, and even administration of periodical insulin injection if the patient needs it. Okay. So we have our second stage now, which is non-proliferative diabetic retinopathy. Okay. And yeah, here we go. The slide glitched, but here it is. So let's start with the pathophysiology here. So parasite damage is now, from the first stage, is now starting to seriously weaken the basement membrane of the capillary wall, which leads to parts of the wall ballooning out. And so these are called microaneurysms, which you can see right here in the conceptual picture. See, blood flow is going to be moving this way. It's going to be keep pumping through the capillary, right? And so there's going to be a weak part of the wall. And once blood hits that wall repeatedly creates a balloon, okay? So these microaneurysms are actually visible on the fundoscopy. You can see all these little red dots. They appear as little red dots there. You can't actually see the capillaries because remember, this is all within the retina, right? But you can actually see these microaneurysms here, all these little red dots. Okay, so we have weakening of the basement membrane, and it also increases the permeability of the capillary wall, like we saw back then with the AGE proteins, right? And so proteins and lipids begin to leak from the capillaries now into the retina, okay? And so these are known as hard exudates. And obviously you can see up here, these are the hard exudates. They come up as like yellow splotches in the fundoscopy. So yeah. So if these microaneurysms burst, it can also lead to intraretinal hemorrhage, so intraretinal bleeding, essentially. And so this in turn can cause diabetic macular edema, which is very which can cause vision loss, essentially. So over here, if we look at this conceptual slide, you can see that the microaneurysm bursts right here, and it causes the swollen retina. And so this doesn't necessarily happen at the macula, but if it were to happen at the macula, then it would be considered diabetic macular edema, right? We also see some exudates that are leaking out. So yeah, so the vocab of this slide, right, the macula is the area of the retina responsible for center vision. So there would be vision loss of center vision specifically, okay? And you can see these hemorrhages right here. They're actually bigger red splotches. All right, so what are the health implications of these hemorrhages, microaneurysms, and hard exudates? So diabetic macular edema specifically due to hemorrhage may cause forms of vision loss, including the blurry or wavy vision near the center. And it makes sense because the macula is your center vision of the field of vision. And so in this second stage, we find that the magnitude of symptoms actually really depends on the patient's blood glucose control. Okay, and so with better blood glucose control, there's less symptoms. although there are still a large number of patients that are asymptomatic at this stage. So the variety, although you can still see it in the fundoscopy. So the variety of symptoms are dependent on the patient's pathology of the disease and NPDR, non-proliferative diabetic retinopathy. For example, hard exudates that are deposited in the fovea region can also cause severe vision loss in the center. And hemorrhage near the macular region, like we said, can cause macular edema. All right, here we go. So this is what diabetic macular edema vision loss looks like. On the left, you have normal vision illustration. And then on the right, you have that blurry, wavy vision around the center. And so this is also called metamorphopsia. Okay, so what is the treatment and prevention of the second stage? So the prevention of this stage, like the first stage, is synonymous with standard treatment of diabetes mellitus, which the most important part of that is the control of their blood glucose levels. Okay, but the diabetic macular edema, if it does happen, can be treated with laser photocoagulation. So what does laser photocoagulation mean? It's essentially the ophthalmologist will use a focused laser to seal off leaking blood vessels in the retina, which reduces hemorrhaging and edema. So he basically seals it with the laser, which I think is pretty cool. You can see the during image shooting a laser at the hemorrhage spot, and then after the hemorrhage is gone. Okay, so we have our third stage now, proliferative diabetic retinopathy, which is also known as the late stage or the advanced stage. So let's start with the big picture, because this is essentially the meat of diabetic retinopathy, right? So this stage is a large part of the reason why diabetic retinopathy is the #1 cause of blindness in adults in America, okay? So proliferative refers to the creation of new blood vessels in the retina due to excessive blood vessel damage. And obviously, this is proliferative in the context of diabetic retinopathy. Of course, it can mean proliferation of other cells in other places. But for now, we're just talking about the creation of new blood vessels in the retina, right? And this is due to excessive blood vessel damage. So this is the main symptomatic stage of diabetic retinopathy, visual symptoms, of course, and it occurs years after initial diagnosis of diabetic retinopathy, around 20 to 30 years, something like this. So let's talk about the pathophysiology. So all of this retinal vascular damage that we've been keeping track of in the first and second stage leads to retinal ischemia. Now, what is retinal ischemia? Retinal ischemia or ischemia is an inadequate blood supply to an organ. In this case, retinal ischemia would be an inadequate blood supply to the retina, right? So this inadequate blood supply in turn causes decreased oxygen delivery, right? Because obviously oxygen is carried in the blood and hemoglobin, right, in red blood cells. So if you don't have a lot of blood going to the retina, then you're obviously going to decrease the oxygen delivery, which is also called hypoxia, okay? So you have retinal hypoxia here, and in an effort to maintain homeostasis with oxygen levels, cells in the retina will begin to produce something called the vascular endothelial growth factor, or VEGF, okay? And this promotes the creation of new blood vessels in and even out of the retina into the vitreous body. Remember the vitreous humor, the clear gel inside the eye. And so this creation is called neovascularization. Okay, and if we look at the image on the left, you see this ischemia leading, it doesn't show in the image, but it leads to hypoxia. And so this hypoxia starts a homeostatic change where they need more oxygen, right? So how would they get more oxygen? More blood flow. So they increase VEGF, vascular endothelial growth factor, which then leads to the abnormal preretinal neovascularization, right? And so this is just new vessels, which you see right here. So, hold on. All right, so here's a picture of these blood vessels in a fundoscopy. They're really small vessels, but they are visible. And so these are typically the first signs of the third stage, proliferative diabetic retinopathy. So, well, what's wrong with new blood vessels, right, Dr. Zubek? What's wrong with new blood vessels? So here we have, here's the another slide of pathophysiology here. So these new blood vessels are abnormal. So we create abnormal blood vessels to fight against the hypoxia. And so these blood vessels frequently leak blood into the retina, and they can even rupture completely. They're poor quality, weak blood vessels, right? And so since these new blood vessels are also found in the vitreous humor, they can cause vitreous hemorrhage as well. And I mean, look at that damage. I mean, you can tell that's like in front of the retina. Just terrible, right? Okay, so we have our symptoms and treatment. So the symptoms of this vitreous hemorrhage can cause temporary blindness if it occurs near sensitive areas like the macula. I mean, you could imagine all of that blood blocking, just blocking light from entering the eye, right? So temporary blindness. And so the retinal detachment is also a possibility, which leads to permanent blindness. And retinal detachment, essentially, the way it works is that damaged blood vessels like those eventually start to create scar tissue. And so this scar tissue pulls on the retina and detaches it from the actual back of the eye. So it actually detaches the retina, and this leads to permanent blindness. So what is the treatment? What are the procedures that we need to do to help patients who have this, right? So there's anti-VEGF injections like avastatin. If you remember, VEGF is what started this neovascularization in the first place. So if we inject something that would inhibit VEGF, then we wouldn't have the neovascularization, right? And then we have the panretinal photocoagulation, which is kind of similar to the laser photocoagulation, except this time we're getting rid of the abnormal blood vessels. So you can see here in the image, all those little white dots, those used to all be abnormal blood vessels. And I mean, you can still even see some blood vessel growth even after the procedure was done, but you can see where the laser essentially sealed the abnormal blood vessels, which I think is really cool. Look how many times they shot that laser in there. And then we have a vitrectomy. And so a vitrectomy is removing the entire clear gel, the vitreous humor, and the hemorrhage all together. Okay. So we have our overview here. So we start with diabetes mellitus, right? Because it's diabetic retinopathy. Okay, type 1 or type 2, and can sometimes occur in pregnancy because of hyperglycemia, right? So we start at the capillary level. So this increase of glucose, again, we're not going to talk about sorbitol, okay? But it starts with increase in glucose causes an increase of the advanced glycate end products. And so these advanced glycate end products eventually lead to the parasite loss, the increased membrane permeability, and even thickening of the capillary wall. And so this damage, as it builds up over the years, you start to see some intraretinal hemorrhaging. You start to see some proteins, lipids leak through called hard exudates. And then you start to see some sorry, it's escaping me. Some microaneurysms, right? Microaneurysms, those little red dots. Okay, and so after that, after all that damage builds up over the years, with poor blood glucose control, you eventually get ischemia, okay, because of the decreased blood flow, which leads to decreased oxygen feeding to the retina, right? Which then promotes the homeostatic negative feedback function of increasing VEGF, and vascular endothelial growth factor, which then leads to the vessel proliferation, right? We're in the third stage now. And so these creations of these new vessels are actually abnormal vessels. So they don't work well, poor quality, they leak, rupture often, which leads to bleeding. And so this bleeding can either be essentially the vitreous bleeding, which can cause the total blindness, temporary blindness, and also cause macular edema, like in the second stage, which macular edema can cause that blurry or wavy vision, right? So, so yeah, after that bleeding, then That's essentially the pathology of the disease, right? You get retinopathy, the loss of vision at the end if it's not treated or I guess not prevented with the correct measures. So thanks for watching. And here are my sources. Thank you.